Hello everybody, Dr. Ryan here, board certified specialist physician. Thank you so much for joining me today. Even as we look at a head-to-toe clinical approach to the problem of hyperthyroidism. If you haven't yet subscribed to my channel, I strongly encourage you to do just that. Alright, as customarily the case, we're gonna first up introduce ourselves to the patient, position the patient, ideally sitting up, Fowler's position, and obtain adequate exposure. Right. So first up, just step back and make your usual inspection. First up, look at the neck. Is there a goiter? If there's a goiter, you want to inspect it for nodularity and motion on swallowing. So you give the patient a glass of water, tell them to take a sip, and you notice the motion of this goiter or this mass on swallowing. Right. On palpation, you gotta palpate for the consistency. Is it hard or soft? The tenderness, right, tender or non-tender. Any discrete cysts, any fixation to overlying skin or underlying structures, any adenopathy in terms of regional adenopathy. Test for Pemberton sign. Pemberton sign is a sign of thoracic outlet obstruction. So essentially what you do is ask the patient to raise both arms for at least 60 seconds, and what you're going to see is facial plethora, non-pulsatile elevation of the jugular venous pressure. You may even see stridor. Okay? And then you percuss the sternum check for retrosternal extension, right? Then you auscultate this beautiful goiter to check if there's an overlying bruit, which speaks to the increased vascularity of the gland, often in the setting of hyperthyroidism or a venous hum. And of course, listen to the voice. Is there stridor or is there hoarseness, right? So that speaks to compression of the recurrent laryngeal nerve, right? Or compression of the upper airway by this goiter. Right, the eyes, there's lots of signs to pick up in the eyes. Does the patient have a so-called stare, where you can see the sclera, which is above the iris, right? Can the eyes be closed by the eyelids, first of all? Excuse me. Got a frog in my throat today. Exophthalmos. So you look from both above and from the side for exophthalmos. Check for lid lag and lid retraction. Check for chemosis, which speaks to swelling of the conjunctiva. Does the patient have a subjective sensation of diplopia or ophthalmoplegia, which means paresis of one of the muscles that control extraocular eye movements? All right, so ophthalmoplegia. Is there impaired convergence? How is the visual acuity? And do a proper corneal and fundal examination. We'll talk about the clinical activity score just now, right? Then you look for any lymphadenopathy, which may be generalized. Look for gynecomastia. Yeah, you check for cardiomegaly, so the apex is going to be displaced. An extra heart sound because thyrotoxicosis is indeed a high output cardiac state. Loud first heart sound, systolic flow murmur, the means Lerman scratch, right, which happens with hyperthyroidism. Systolic hypertension or hyperthyroidism, irregular, large volume pulse, right? So inevitably you have a wide pulse pressure, splenomegaly, and a tender spine if there's concomitant osteoporosis. In the hands, well, some of us like to examine the hands first. Right, but what you're going to find is a fine tremor, and this may not declare itself normally. What you do is ask the patient to hold their hands out like so, and place a sheet of paper on top of it, and you notice there'll be a fine tremor. Right, the patient may have sweaty palms, thyroidocropicy, which is a fancy way of saying clubbing in the context of Graves' disease, capillary pulsations, onycholysis called plumber's sign, and palmar erythema. All right, and the legs, notice any proximal weakness. Okay, pretibial myxedema, fasciculations, edema, and brisk reflexes, as opposed to hypothyroidism, where you get the so-called hung reflexes. And of course, temperature. The patients are often pyrexial sometimes. Okay, important questions to ask a patient in whom you suspect hyperthyroidism. Right? Let's start with the important ones first, because the ones with the exclamation mark denotes the symptoms with a possible diagnosis of an urgent, dangerous problem. Have you had any palpitations? Thyrotoxicosis can, of course, present with the commonest arrhythmia in clinical practice being atrial fibrillation, which may precipitate heart failure. Then ask them, have you had a history of thyroid problems? Have you ever had a family history of thyrotoxicosis? As there is a familial incidence of Graves and associated autoimmune conditions such as vitiligo, Addison's, pernicious anemia, type 1 diabetes, myasthenia, premature ovarian failure. All these autoimmune family tends to stick together. Right. Have you ever taken amiodarone or thyroxine? Because we know that these can precipitate thyroid issues. Amiodarone can cause, we have something called the Wolff-Chaikoff effect and the Jod-Basedow phenomenon. The Jod-Basedow phenomenon causes thyrotoxicosis on the back of amiodarone intake. Have you ever had recent exposure to iodine? As we know, iodinated X-ray contrast materials can precipitate thyrotoxicosis, usually in patients who have an existing multinodular goiter. Have you noticed insomnia, irritability, or hyperactivity? Those are symptoms that keep company with hyperthyroidism. Have you had any loss of weight, diarrhea, increased stool frequency, increased sweating or heat intolerance? Have you had muscle weakness? Because proximal muscle weakness is common, and the patient may have noticed difficulty getting out of a chair, difficulty combing their hair, difficulty climbing stairs. You know the story: chairs, hairs, and stairs. Have you had any eye problems such as double vision, glutinous, redness, or pain behind the eyes? Important for us, guys. Okay, here is basically a patient who has a thyroid stare. See, you can see the sclera above the level of the iris. Okay, and exophthalmos, and this is onycholysis, which is what we term plumber's nails. Okay, so in terms of grave orbitopathy, there's a specific clinical activity score that we look at. Okay, and there's basically a couple of parameters here, right? So we're just going to go through this. Remember, for each item, 1 point is given. The sum of these points is the clinical activity score. A composite score of 3 or more means you want to use corticosteroids in this patient. 2 or less means we can just use conservative measures like selenium and protective eye drops, etc. So the first parameter is pain. So you get 1 point if you got an oppressive pain feeling on or behind the globe during the last 4 weeks. 2 points if there's pain on a tinted upside or down gaze during the last 4 weeks. The next parameter is redness. So you get redness of the eyelids or diffuse redness of the conjunctiva, covering at least one quadrant. Swelling, where there's swelling of the eyelids, 1 point. Chemosis, 1 point. Swollen caruncle, 1 point. Or increase of proptosis of greater than 2 millimeters during a period of the preceding 1 to 3 months. Impaired functioning is the other one, with decrease of eye movements in any direction during a period of 1 to 3 months, or diminished visual acuity. Remember that a composite score of 3 or more means you probably want to use steroids in this patient. 2 or less can be managed conservatively. Okay, guys, the causes of thyrotoxicosis, I have an entire video dedicated to this topic. I encourage you to have a look at that. But just a bird's eye view, you get primary and secondary, right? So primary, where the problem is not the pituitary, the problem is actual thyroid gland. Graves' disease, right, is probably the commonest, where there's production of anti-TSH receptor antibodies which dock into the thyroid gland, causing increased endogenous production of thyroid hormone. Toxic multinodular goiter, toxic unilateral or unilodular goiter, usually a toxic adenoma. Then you've got Hashimoto thyroiditis, early in its course, so-called hashitoxicosis. And subacute thyroiditis, which is transient, postpartum thyroiditis, which is non-tent, and we spoke about the iodine-induced jot-based phenomenon. Iodine given after a previously deficient diet, also in the context of amiodarone. Secondly, where the problem is not so much with the thyroid, the problem is with the pituitary. Very rare is TSH hypersecretion, but often you get this thing called hydatidform mole or choriocarcinomas with HCG secretion, stroma ovari, and drugs. Okay, my friends, the book of Romans chapter 8 verse 14 says, "For those who are led by the Spirit of God are children of God." How do you know that you're a child of God? You are sensitive to the leadership and direction and the presence of the Holy Spirit in your life, who gives you counsel and who reveals the will of God to you. So if you are led by the Holy Spirit, then you are a child of God. These are my references, guys. Have a lovely day. I'll see you soon with another handy video on this channel in this series. God bless you.